So today and Wednesday we're going to be in acute and chronic inflammation. And this might be, it's not fair to say it's my favorite lecture of the semester, but I'm going to say that it's probably one of the most important. I really do like this lecture because I think it's some of the most valuable information for you for the rest of the semester. If there's one lecture you'll probably continue to kind of come back to, even after you finish this class and you move on, is inflammation. Okay? You have a patient in the chair, you're cleaning their teeth, okay? They've got periodontal disease. Guess what? This is happening in a big way, causing major problems. You have patients that have underperfused tissue, right? You have patients that are wrestling with cancer. You have patients that have traumatic injuries. There's inflammation happening in most of the disease states that are chronic. Inflammation is a huge component of so many different diseases. We'll look at allergies when we look at the immune system, hypersensitivities, right? If you have a food allergy, if you're allergic to certain types of medications, right? I have a daughter that swears that she's allergic to broccoli, but I don't think she is. But she is allergic to shellfish. She has a wicked allergy to shellfish. And when she's exposed to it, we get an inflammatory problem. And a lot of that has to do with her windpipe, and she has trouble breathing. Some of you have peanut allergies. Okay, you're allergic to tree nuts. Fill in the blank. Okay, you're allergic to cats or dogs. And you know that there's something that goes on with your lungs, and we'll talk about the respiratory system, and we'll look at asthma. There's inflammation pathways associated with asthma. If any of you have wrestled with asthma or you get really sick and now you have an asthma attack, they put you on a steroidal medication, which is super powerful. Any of you ever heard of prednisone? Yeah, that some of you are, smiling, probably not of fond memories, but because I just struck a nerve, right? So prednisone, usually you start the patient off really, really high dose, and then you start tapering right away because it's a potent anti-inflammatory. But it's actually dangerous over long periods of time. And so that's why they jack your system up with prednisone, and then they start weaning you off so that you go through withdrawals like within 2 days, right? And usually you're, agitated and angry and moody, and these are all the side effects of having a monster steroid on board. So those asthma issues are due to inflammatory problems. So not all, but so many of the diseases that you're going to interact with are going to have an inflammatory issue associated with them. Right now in the news, what's the disease of the day? The coronavirus. So viruses, do they use any inflammatory or stimulate any inflammatory pathways? Think so? Yeah, that's a safe bet. For sure. So this coronavirus, unfortunately, is really specific to lung tissue, and patients end up seeing symptoms that resemble pneumonia. Okay, so there are inflammatory issues associated with this particular viral disease that we're worried about right now, even though it's a virus and not a bacteria. Right? It's easier to think, bacterial infection, lots of inflammation. Viral infections can stimulate inflammatory pathways just as much. Okay? So that's my little segue into inflammation. There's some critical things that we need to cover over this week. And so we're just going to walk through them. We're going to walk through them methodically. But right now what I want to explain to you is the importance of inflammation for the survival of the species. And many, many organisms have inflammatory pathways as a defense mechanism, not just humans. And so you can study inflammatory pathways in other types of model systems. And so as a biologist, we would say this is a pathway that is extremely highly conserved. You guys have heard that language before? That just means, this is really important, okay? If earlier life has the same process and can do some of the same things, and evolutionarily speaking, we conserve that trait or we continued it through, that means it was important. If it wasn't important, we would have dropped it. We wouldn't keep doing it, okay? So, the survival of the organism requires that they're able to eliminate foreign invaders and threats, like infectious agents or pathogens, or even damaged tissues. Damaged tissues can be a problem, especially if the infection becomes more systemic. Inflammation is the body's answer and its protective mechanism. Now, it's not the only protective mechanism. We're going to talk about others when we get into the immune system. But right now, I'm just introducing one of the first ones that we're going to talk about. Inflammation is defined by immunologists as part of our innate immunity. So that means you're born with it. You don't have to educate it. It comes preloaded. It's like software that's already on your device the moment you turn it on. Okay? It also means, innate also means that it is the same in every one of us. There's nothing customized about it. It doesn't learn. It doesn't remember. It does the same thing every time. That's why if you have inflammation and you give it an anti-inflammatory and then it goes away and then you have inflammation again, you can give it the same anti-inflammatory, okay, at the same dose. So you don't have to dose escalate because there's some learned behavior. Now, we have a learned immune system as well. We're going to talk about that in the immune section. But it's part of our innate, other types of defense mechanisms are part of our innate immunity. Give me some examples. You're born with it. Skin, perfect. What's that? Mucous membranes, okay, even hair, okay, like eyelashes, for example. All right, first line of defense, our innate immunity. So we've got nonspecific, we have barriers, beautifully stated. Skin is a physical barrier or mechanical barrier. We also have biochemical barriers, as well was stated, mucous membranes. And what I want you to be able to appreciate is that these things happen very early on. Our innate immunity with these phagocytic cells, which tend to be most commonly referred to as macrophages or tissue macrophages. These are part of our innate system. Here's our adaptive immunity that we're going to get into. These are our lymphocytes, our B and our T lymphocytes. Now, the B lymphocytes are in the business of making antibodies. And the T lymphocytes are in the business of either facilitating the immune system response, or in the case of a effector T cell like a cytotoxic T cell, it goes out and kills an infected cell, like literally attacks it. So we'll come back to this particular example, but when we look at our first line of defense is our innate immunity as it relates to barriers. Our second line of defense is inflammation. And then our third line of defense is our adaptive immune system, like our lymphocytes, and we'll talk about that later. We're not going to spend a whole lot of time talking about the barriers and mucus. You talked a lot about that in anatomy and physiology. We'll come back to skin as it relates to our healing lectures. But what I want to spend most of our time on is inflammation in the remaining time today. So this is a picture of a blood vessel that's been cut away. So it's a longitudinal section, and the blood is flowing from left to right. And you're seeing at the interface here endothelial cells. So those are the tunica intima, and it's a monolayer of endothelium, and they're interfacing with the blood, and then they rest on the basement membrane. And it's not just up and down, it's 360, right? So it's a tube, and you have a layer of endothelium all the way around. But we've sliced this diagram, and for cartoon drawing's sake, we're not showing the endothelium in the background that's on the back wall. Does that make sense? So, in the bloodstream, we have a tremendous number of components that are interesting to us. We've got plasma proteins, And we've got these cells that can be recruited out of the bloodstream. And then we have platelets that help facilitate clotting. Now, the cells and the cellular recruitment is critical because that's where we trigger an immune response with respect to inflammation, and we literally signal those circulating monocytes to extravasate, to migrate out of the cell and become what we refer to as tissue macrophages. And so that's what we're going to spend most of our energy on in the remaining time, is looking at these details of how this takes place. Make sense? Hopefully you can appreciate that these endothelium are closely connected. They're connected by a molecule known as connexin. And this connexin molecule keeps them closely linked. They have cadherin or adhesion proteins is what this is the family of. And you can break those connections and create a gap. And when you have a gap, you can allow for certain things to leak out. And if it's a small gap, you might just leak out fluid. If it's a large enough gap, then you can leak out cells and proteins. Okay? So that's really the secret of inflammation, is it's a recruitment effort of mediators out of the bloodstream to the tissue. So if you have damage down here, outside of the blood flow, you open up the gap in between the endothelium, you allow for fluid to leak out and some plasma proteins to leak out. That includes certain cytokines, and that recruits these macrophages to migrate out of the cell. And then those macrophages can end up in the tissue, and they help facilitate the repair. What do they do there? Well, oftentimes these macrophages are phagocytic cells, so they clean up the debris. They clean up the dead tissue. And that's kind of the first step of allowing for a repair process to happen. All right. Third line of defense I alluded to is the adaptive immune system, and we'll get there in a future week. So I want to talk with you a little bit more specifically about the vascular changes that take place with acute inflammation. We're going to characterize and spend our time in acute inflammation, and then later, probably Wednesday, we'll come back and we'll talk about chronic. And they're very similar. In fact, they have all the same features, except they differ with the amount of relative time. So acute inflammation is talking about early and rapid time, and chronic is saying long term. So if you have a cut or you trip and fall and sprain your ankle, that's going to trigger acute inflammation. And then it's going to come up and it's going to subside and you're going to heal and you're fine. When it's a problem is when it comes up and stays elevated and it moves from acute inflammation to chronic inflammation. And so the disease states that we worry about are chronic inflammation. So let's go back to our first clinical example the first time we met. We talked about GERD. You guys remember GERD? Gastroesophageal reflux disease. So GERD, do you think that there's any inflammation that's happening with GERD, with hydrochloric acid coming up the esophagus? Yeah, that's where the irritation happens from. Now, if it's acute, like every now and then you get, oh man, I ate way too much pizza, okay? Every now and then you have a little bit of reflux. Not a big deal. But if you have GERD every night for 20 years, is that acute inflammation or is that chronic? That's chronic. And that's the risk factor for developing esophageal adenocarcinoma. Okay? So the chronic inflammation state is the more dangerous of the two. Acute inflammation is actually important. Like you need it to heal. You won't allow healing to take place if you eliminate the acute inflammation phase. And we'll talk more about that later. So local characteristics. 4 main categories of inflammation acutely. We've got pain or dolor. We have redness, rubor, heat, calor, and swelling or tumor. And all of these can be easily explained as a result of increasing blood flow to damaged tissue. Okay? Blood is warm. So if it moves into the area, you get heat, warm to touch. Think about you spraining your ankle. It's warm to touch. Right? Then you get swelling. I don't have to convince any of you that that happens when you sprain your ankle. It probably turns red because you're bringing in blood flow to the area. And then the pain. Why the pain? Well, as you increase the pressure in the tissue with more fluid, your nociceptors, which are your pain receptors, they detect that. And then they signal the brain that there's an uncomfortable feeling there, and that's where that dull pain is coming from. So all of these characteristics of inflammation can be attributed to an increase in blood flow into the tissue. So what happens to the vasculature? Well, this is a normal capillary network, and this is an inflamed capillary network on the bottom right. So in our normal capillary network, we have an arteriole bringing blood flow in on the left, or the red portion, into the capillary bed, and the venule is the outflow on the right side. You can see an occasional resident macrophages, not a big deal. Those are called sentinel macrophages. They kind of keep watch. Remember, they're part of the immune system, so they want to, if there's any foreign invader, they want to get on top of it right away. So you've kind of have some lookout cells there. But look what happens when you increase blood flow in an inflamed situation. You dilate, meaning you make the vessel larger. So you vasodilate the arteriole. That increases the amount of blood that can flow in. You expand the capillary bed. You dilate the capillary network. And if you have endothelial cells that are closely connected and you make the diameter larger, what happens to those connections? They come apart. So that's where the gaps occur, is because you vasodilate. And you stretch out the vessel, you don't increase the number of cells like this. So the cells are plastic, but they're not that plastic. And there are other mechanisms that are in play where the cells themselves are going to become less flattened and more round, and that will also create more gaps. So the result is we get an expansion of the capillary bed, a larger diameter with holes, and you get the leakage of fluid, proteins, and cells can immigrate out. Here's one right here where the cell is actually kind of almost all the way out, but still has a little bit of it, the back end of it still within the vasculature. And you dilate the venule side as well. So in response to injury, we get a rapid change of the vasculature. And there's two main things. We get vascular changes of what's known as vasodilation, and then we have cellular contributions where we recruit cells out of the vessel into the extracellular space. So, to continue, this vasodilation causes a slowdown in blood flow in that area momentarily because you've just made the diameter of the vessel larger really quickly, and so blood comes to a halt. That's important because this vasodilation leading to a temporary stasis of blood flow gives those circulating cells that are inside the bloodstream time or the ability to attach to the vessel wall and then to leave. Make sense? We have an increase in permeability because we've got the gap of the endothelial cells that took place. Increasing permeability allows for stuff to leak out. We've got cells that pull apart. We get transudates, and we get exudates that follow. Can anybody define what transudates and exudates are? It looked ahead. Transudate. Who can define a transudate for me? Transudate is the leakage of fluid only, and the exudate is what? Other stuff too. So it's fluid and protein. So let's hold off on this increase on oncotic pressure until we talk about this slide right here. So transudates and exudates is like I just characterized. Here's a normal vessel. We've got these orange dots in the middle, which are plasma proteins. And normally, there's sort of a balance between hydrostatic pressure, which is the blood pressure that forces fluid out. Okay? So you have a tube, it's pressurized. So there's going to be some amount of fluid that leaks out of a pressurized tube. Right? It's not sealed. And then we've got colloid osmotic pressure. That refers to this concept that water follows solutes. So the proteins that are in the bloodstream create a huge pull of colloid osmotic pressure, where fluid wants to reabsorb into the bloodstream because there's a lot of protein in there. And that's referring to colloid osmotic pressure. That is the reason that all of your blood doesn't just leak out of your blood vessels, right? And you're just kind of a gloopy bag of fluid. The reason the blood reabsorbs into the venules is because inside the blood vessels, you have a high content of protein. And that encourages the reabsorption of fluid on the venule side. You with me? So, in a transudate situation, we increase hydrostatic pressure, we allow for fluids to leak out, and we decrease colloid osmotic pressure. In an exudate situation, we get larger gaps, and now both leak out, and the proteins leaking out encourage more fluid to follow. So if you have an inflammatory situation where you've got significant vasodilation and an increase in blood flow into the sprained ankle, you can imagine how much fluid and protein and then more fluid is going to move into the tissue and why it swells so much. And so if you take an anti-inflammatory, right, and you lower inflammation, you can see why the swelling goes down. Does that make sense? Okay, question. Yeah, this is innate.
Yeah, so it's no matter what you do, it's still going to come back to inflammatory.
Yeah. So the answer to your question is, if you look at inflammation on a graph, okay, and it's going to come up and then it comes down. And acute inflammation will come on in 24 hours, and then it really should resolve by like 3 to 5 days, somewhere like that. So the problem is, if this comes up and stays elevated, now this is chronic. So this is a normal process, and we'll do this again and again and again because it helps with healing, because getting the fluid and the protein and then cells out is a good idea. But then after everything is healed, you want to reverse it. Yeah. So the vascular changes. Just a different representation of the blood vessel, sort of normal permeability of the capillary, and then an increased permeability state during inflammation. And what I want you to appreciate in the increased permeability state during inflammation is there are gaps in between the endothelium where these fluid and proteins can leak out. And some of the things that leak out are shown on this particular slide. They're chemical signals. And these chemical signals help to facilitate repair. So for example, the vasodilation that allows for rapid swelling of the vessel is because of histamine that's released by mast cells. Now, in a dangerous situation or sort of an unregulated situation, this is what happens during allergies or allergic reactions. You get a tremendous amount of histamine, and then all of a sudden all the tissues get red and there's too much fluid and you get swelling. Same histamine. But here, it's trying to target the vessels to get all of the good stuff that you need for healing out. Okay? So that's what histamine's all about. We also have these compounds known as cytokines, like TNF-alpha and interleukin-1. This is tissue necrosis factor alpha and interleukin 1. The names of some of these molecules are really confusing. And I'm sorry for that. That's just the way biology is. But the reason for it is because a lot of them were discovered in other fields, and so they're named by their inventor or their discoverer based upon what they were researching. So what you need to know is that TNF-alpha, or IL-1, which stands for interleukin 1, these kinins help to facilitate an increase in capillary permeability. That's the important take-home message, is these guys also trigger capillary vasodilation. And then another one known as vascular endothelial growth factor, or what we call VEGF. Again, back in the 70s and 80s, it was called vascular permeability factor, VPF. And then it got renamed to vascular endothelial growth factor, but it also causes vasodilation and the leakiness of these capillaries to occur. And the reason you want this to happen, hopefully it's obvious, is you want to encourage the fluid to leave and the plasma proteins to leave, and then the ability for certain cells to migrate out. Questions so far on what we've covered? And then you have the opportunity for cells to extravasate or leave the vessel. And that's what we're going to talk about next, is why do you want these cells outside the body? Okay. So, in a timeline, we've got a couple of major steps, and these steps are really important for you to know. So these steps are all going down the process of recruiting repair resources for the tissue. So we have recruitment, activation, and chemotaxis. So I've already told you how we're going to get fluid into the damaged tissue. I shared with you how we're going to get plasma proteins and certain chemicals because we're vasodilating. Now the third thing is we're going to recruit circulating monocytes. And once they leave the blood vessel and they squeeze through the little gap, and I'm going to show you a video, squeeze through this little gap, which is called diapedesis or extravesiculation, they leave, they exit out of the vessel into the matrix, the extracellular matrix. Why? Well, they become tissue macrophages and they're phagocytic. So they can go and gobble up all the debris from the trauma, and that helps to stimulate the repair process. Back into the bloodstream. Usually once they become tissue macrophages, they stay there. Yeah, they don't kind of go back. You make new monocytes to kind of it's like a one-way ticket, man. Yeah. Okay? So, recruitment of these monocytes. See this little fuzzy ball cell? We're going to recruit this thing. We're going to allow it to roll and then seat down and bind, extravasate out, and it's going to go and chemotax to this area of inflammation. So we've got some molecules that help do this. So on the endothelium, we've got molecules known as selectins. And these selectins, what they do is they kind of make the endothelium a little bit sticky or tacky. And as they make the endothelium sticky, the monocyte grabs and the blood flow breaks it loose. Then the monocyte grabs and the blood flow breaks it loose. And that action of binding and releasing triggers an upregulation of integrin molecules to be expressed. And the integrin molecules are a much stronger bond. So instead of, grabbing lightly and then releasing with the blood flow that's hitting the cell, with an integrin, they grab and they stick. And when they stick, they spread out. And as they spread out, then they start to crawl and they slide through. Okay? And once they're out on the other side, they're tissue macrophages. So let me cue up this video, which explains this. Nope, sorry, here we go.
Sites of inflammation. Chemokines secreted by endothelial cells bind to the extracellular domains of G-protein-coupled membrane receptors. This binding causes a conformational change in the cytosolic portion of the receptor, and the consequent activation of a subunit of the G-protein. The activation of the G-protein subunit triggers a cascade of protein activation, which in turn leads to the activation and clustering of integrins inside lipid rafts. A dramatic conformational change occurs in the extracellular domain of the activated integrins. This now allows for their interaction with ICAM proteins displayed at the surface of the endothelial cells. These strong interactions immobilize the rolling leukocyte at the site of inflammation. Additional signaling events cause a profound reorganization of the cytoskeleton, resulting in the spreading of one edge of the leukocyte. The leading edge of the leukocyte inserts itself between endothelial cells, and the leukocyte migrates through the blood vessel wall into the inflamed tissue. Rolling, activation, adhesion, and transendothelial migration are the 4 steps of a process called leukocyte extravasation.
Okay, that's the very end of this like 8-minute video. There's some really cool stuff early on that I think you guys should watch. I just want those of you that are visual learners to have an idea of this whole recruitment concept. Okay, so we're going to walk through this on this slide, and this is probably one of the most important pieces of today's lecture, is that you understand this stuff right here, right now. Okay? So if you're this is the time to kind of wake up, write some stuff down. Okay? So we've got a couple of stages. And we've already said, why do we want the cells out in the tissue? Well, they're going to help with the repair. How do we get the cells there? They got to leave the blood vessels. How do they leave the blood vessels? Well, you dilate the blood vessel. You create little gaps. Then, in the video, you could see the blood flow just shooting by, right? You could see the red blood cells kind of firing through at high velocity. Then you got this kind of doo-doo, doo-doo, this cell kind of just doing its own thing. Because it's been recruited. It's been activated. It's going to adhere, and then it's going to crawl out, and then it's going to chemotax to the site of injury. This is all happening in tissue damage. So, we call this margination, rolling, and tethering, kind of step 1, 2, 3. What the heck does margination mean? Margination means move to the margin. So, if you look down fluid dynamics of a blood vessel, the vector profile of blood flow is that it's fastest in the middle. So the vector profile means that it's going to do this. So you have the highest velocity right down the center, and then you have lower velocity on the edges. You guys remember vectors? So the size and magnitude, so it's got size or magnitude and direction. So the large arrow means that this is a faster velocity than a small arrow. So if you have a cell that's sitting smack in the middle, it's going to move faster than if you have a cell that's on the edge. That's what margination means. So we create a controlled clot. We coagulate the blood slightly. And that encourages these leukocytes, these monocytes, to marginate. They move to the edge where the velocity is a little slower. It also means when they move to the edge where the velocity is slower that the interaction with selectins occurs. Those are weak affinity bonds. So they'll stick, and the blood flow is still behind them. They're kind of like a sail, and then they break loose. And as they break loose, they're round, so they roll. So the breaking and rolling action, the rolling, triggers integrins to be upregulated, just like the video showed. Integrins don't just play around with a little bit of stick. They grab on. And now that monocyte is stuck. It's not going anywhere. And as it sticks, then it kind of takes on kind of like a seated position, like, all right, well, I'm not moving, man. You are not moving me, right? And so it adheres and flattens. And you saw the video representation of it kind of spreading out. So now we're at adhesion. Then it starts to diapedese or transmigrate or move extravascularly. Okay, and now you've got the cell. One second, Max. You got the cell out into the tissue, and the last step in this process is it chemotaxes to the site of injury, so it can be used. So it's like recruiting a soldier to the battlefield. You guys with me? Max, question. Yeah. Yep. Yeah, so Max saying, you saw in the video, it flattens, and it kind of flattens in a certain direction, almost like a teardrop shape, because the blood is pushing on its back. Directional flattening? I don't know. Maybe we should name it. Yeah. It's the Max Robb phenomenon or something like that. We'll name it together and take credit for it. How's that? No, that's a great observation. Any other questions? Not too much, right? Not too difficult. But, I mean, you might have to marinate on this a little bit. This is really critical. This is a very important step in this whole process of inflammation. Okay. So, we're going to come back to these slides. I want to just show you, I want to leave today on 2 slides, and we're going to come back to those other ones Wednesday. This is a scanning electron micrograph of a macrophage. That's what we've been learning about. It's a tissue macrophage. And it is moving, its main body is down here in the lower right. And this is from the Harvard Medical School, so you know it's a really intelligent macrophage. And it's moving to the upper left. It is literally crawling on this substrate from lower right to upper left. Now, one last picture before we part. This was a photograph. Don't read it. Just look at the picture. Try to just look at the picture. What do you think that picture is of without reading the text? What's that? Red blood cells. That's a good guess. I've had people say it looks like the moon. So this was a cover of a scientific publication that I grabbed, and I was just reading it casually, and I thought, oh, this is perfect. These macrophages, folks, these macrophages are capable of amazing cleanup process. If there is a foreign object, this foreign object in the background is a cobalt chromium hip implant. And the macrophages, this is at explant, after having this in the patient probably for a few decades, these macrophages are trying to digest the hip implant, and those are the pits of the digestion spots. They're not successful. But cobalt chromium hip is being pitted by macrophages. They're trying to get rid of it because it's a foreign object. Now, that's a hip implant. If it was a bacteria, right? If it was a virus particle, right? They're much more successful. But I just want to give you an example. They will break down cobalt chromium metal. Okay? If they were large enough, they would eat the whole thing, but they're not. Okay? See you guys on Wednesday.